Hello and welcome to the Patient Story. I'm Andrew Schorr, and with us is one of my favorite CLL researcher and experts. He's from MD Anderson, Dr. Nitin Jain. Thank you so much for being with us and filling us in on what's significant for patients from the American Society of Hematology meeting. Thanks for being with us, Nitin.
Sure, absolutely. Appreciate the time.
Okay, so patients like me have lots of questions. We hope we can live a long, full life with CLL, and you have more options than ever before. One of the areas is in BTK, Bruton tyrosine kinase inhibitors. So we have Imbruvica, we have Calibrutinib or Calquence. We have Zanubrutinib that may be approved in CLL before long, but is used in some other conditions. These drugs have made a big difference for people. Would you care to comment on what we know about them now and how you choose which one is right for which patient?
Yeah, so, as you mentioned, Andrew, there are, multiple these drugs called BTK inhibitors. All of them are oral drugs. They target a specific protein called BTK on the CLL cells. And so the first one in the list was Ibrutinib. The first generation, the second generation ones are Acalabrutinib and Zanubrutinib. And as you mentioned, Zanubrutinib is not yet approved for CLL, but we're expecting it to be approved pretty soon, maybe in the next couple of months. And then there's also a third generation BTK inhibitor called Pirtobrutinib, which is again not yet FDA approved, but it's kind of on track. And there's a lot of data presented in this meeting about the drug. So currently FDA approved for CLL are really two BTK inhibitors, namely Ibrutinib and Acalabrutinib. And I think in terms of deciding which drug to choose between these two for my patients, I think I really look at the efficacy and the safety profile of these drugs. And there are a couple of trials done in patients with relapsed CLL, meaning that who had prior therapy for their CLL of some kind, maybe chemotherapy, maybe something else. And then their disease came back, and then we give half of the patients were given Acalabrutinib, half of the patients were given Ibrutinib. And what those studies showed is that those drugs were equally effective, but less toxicity with Acalabrutinib. So based on that and some other data, I think my practice, I'm preferentially using Acalabrutinib these days as a BTK inhibitor of choice for my patients. Again, that argument may change a bit, or may when Zanubrutinib comes in the picture. And certainly down the line, when we get Pirtobrutinib, that will be another, exciting addition to the field of BTK inhibitors.
Okay, so that's really going to be sort of physician and patient choice, it seems. I mean, they're all good drugs.
Right. No, absolutely.
They're all good drugs.
Right. So I think it will come down to the physician, how comfortable they're using in a particular drug for their patients. And the medical data is kind of emerging and how they kind of look at it. And I think as I mentioned, I present all these options to my patients, discuss some of the clinical trial data in kind of big picture view, and then give my recommendations to the patients for the treatment and obviously follow what their wishes are.
Okay. And then also in this discussion is what other conditions a patient might have, right? Do they have a heart condition or other things that would determine which medicine you might go with, correct?
Correct. So I think you're absolutely correct. So one of the things, we're concerned about BTK inhibitors is some of the side effect profiles. So some of the side effect profile are kind of, bone aches and muscle aches and diarrhea and skin rash, which certainly can be an issue, and some patients require dose reduction, especially for Ibrutinib. But sometimes some things are somewhat less common, but can be more serious, such as atrial fibrillation, which is an abnormal rhythm of the heart, or hypertension, which can become a problem for some patients, or bleeding issues with these drugs. So I think if a patient has some of those medical conditions ongoing, they have heart issues, they had a recent maybe a heart attack, or they have a heart rhythm issues, then I think I personally try to sway away many times from BTK inhibitors and use a drug called venetoclax, which is a BCL2 inhibitor. Or even among the BTK inhibitors, that will really make more case from using second generation agents, which are less toxic in terms of cardiovascular side effects.
Right. And I know there's data coming out related to zanubrutinib, not yet approved, but whether there are some safety less concerns related to that for some patients. Am I right?
Yes, correct. So similar to acalabrutinib, zanubrutinib was also studied head-to-head comparing to ibrutinib in relapsed CLL. And in that study, also they showed that there was less atrial fibrillation with zanubrutinib compared with ibrutinib. That's the first time two BTK inhibitors were compared head-to-head, and they're also showing that one is more efficacious than the first
one. Okay, let's just talk about the one that's been around a long time, ibrutinib. There are many, thousands and thousands of patients on it. If they're doing well, there's not necessarily a reason to change, right?
Yeah, no, I agree with you, and I think that's a very important question from a patient standpoint. And I get asked this question all the time in the clinic because ibrutinib certainly was the first drug in the market, really changed how we manage these patients and really dramatically improved the outcomes of our patients. And but now that we are seeing some side effects of this drug, but there are patients who have been on ibrutinib for years and years, 5 years, 7 years, 9 years, and they're tolerating the drug well, has no side effects, disease is under well control. So for those patients, I'm not switching them to a different agent at this time. We continue to use the ibrutinib for those patients. However, if they're starting to have side effects, then we look into moving to a different agent.
There's a significant percentage of CLL patients who are on watch and wait for an extended time. Is there any new thinking about doing anything differently now, or is that still the standard in CLL?
So I think it's as a group, as a CLL research group, we are actually investigating the concept that whether you can treat certain patients with CLL who are high risk for disease progression early on. For example, patients with deletion 17p and kind of high risk disease, unmutated V gene. So these are the patients where we expect the disease to progress a bit faster, and their time to treatment for their first after CLL diagnosis is probably shorter than kind of other patients with CLL. So currently there are actually ongoing randomized studies in the United States where they're evaluating the concept that patients with CLL who are diagnosed with CLL, they are given randomized to either treat right away with venetoclax-based therapy, or we watch these patients, and whenever the disease progresses, which could be, who knows, several years down the line, at that time they receive the venetoclax-based therapy. So that's an ongoing, a very important trial in the field, which is still ongoing right now, and we'll have to wait some time to get that medical data. Now, before we have that medical data, right now, I would say the current standard still remains the same, that we should watch these patients until they meet ideal CLL treatment criteria, which is basically having low blood counts, low hemoglobin, low platelets, big spleen, big liver, big lymph nodes, or significant symptoms from the disease affecting quality of life. And if you meet those criteria, then only we treat patients with CLL.
Right. I went 4.5 years. Some people go longer. I have one friend who's never been treated, but most people usually go on to treatment. So we talked about single agent therapy with BTKs primarily, but you gave a presentation with longer data on ibrutinib plus venetoclax. So tell us about that and whether that combo has promise for people.
Yeah, so we, both ibrutinib and venetoclax are FDA approved for patients with CLL. And some years ago, back in 2014, our group and many other groups showed data that combined these two drugs together is actually much synergistic for the two in the lab. And based on that, we started this clinical trial of combining ibrutinib plus venetoclax, so two oral drugs together for patients with CLL. So we treated 120 patients at MD Anderson. So these are patients with CLL who need treatment for CLL, but they have never received treatment. So this is the first treatment for CLL. And what we showed is that almost 70% of these patients achieved MRD negative remission in the bone marrow after getting these two oral drugs. And practically, we saw very few relapses over a course of 4 years. So our 4-year progression-free survival was 94%. So that was the medical presentation we did.
So Nitin, first of all, there has been, in combination with some of these drugs, and going back to FCR, the standard therapy over many years, Rituxan, or some people have received venetoclax, but an infused CD20 antibody. But you didn't mention that in that study. How important is it, do you think, to get that infusion versus these oral medicines?
Right. So I think, that's, an unanswered question in the medical field, in the CLL field right now. So we certainly know that the infusion CD20 antibody, whether it's rituximab or whether it's obinutuzumab, works very well when we combine it with chemotherapy. Also works very well when you combine it with venetoclax. There is some conflicting data when you combine rituximab with ibrutinib. It doesn't really work that well with ibrutinib. However, doing obinutuzumab, which is the second generation rituximab, works a bit better when you combine with acalabrutinib. So now, when we combine ibrutinib plus venetoclax together, the two kind of most potent drugs we have in a way for CLL together, we are already seeing very high rates of remissions. So the question is, can you improve that further by adding an antibody? So this is the question of doublet versus triplet, right? 2 drugs versus 3 drugs. And so when we designed the study, we did not elect to use the antibody because we thought antibody may add more toxicity than benefit. However, there are other medical data with triplets, which has been reported as well. So right now, it's very difficult to say because all these drugs are very, very effective regimens. So doublets versus triplets. So it's really difficult to tease out if one is better than the other. But there are ongoing randomized control trials where they are evaluating this very concept, doublet versus triplets. And I'm hoping that we'll hear from some of these trials in the next 1 to 2 years, and then we can have a more informed decision that whether you really need to add CD20 antibody when you're using these 2 oral drugs together.
Doctor, so there you've mentioned pirtobrutinib, which is in trials, a 3rd generation BTK. What would be the advantage of a 3rd generation? How would that be different?
Yeah, so pirtobrutinib, or previously called LOXO 305, is a 3rd generation BTK inhibitor. And the main advantage here is that unlike the first 2 generations of BTK inhibitors, namely ibrutinib, acalabrutinib, and zanubrutinib, they bind to a very specific protein pocket, and they bind to a residue called cysteine 481S. That's the name of a protein, which attaches to these drugs. And these patients, when they relapse from this, they develop resistance mutations. And then these drugs cannot bind to that pocket. However, pirtobrutinib is a non-covalent inhibitor. It does not need that residue to bind. It just blocks the pocket. And that's why it's able to work against patients, or for patients, who have failed ibrutinib or failed acalabrutinib or failed zanubrutinib. So that's one advantage, that pirtobrutinib can work against patients who have failed previous BTK inhibitors. And the second advantage is the safety. So far we have seen excellent safety profile of this drug, with very few patients having atrial fibrillation or bleeding complications or any other major issues.
Now, a small percentage of CLL patients develop a much more aggressive condition called Richter's transformation. Is there progress being made there? Any news from your meeting there in New Orleans that gives hope in treatment for Richter's?
Right. So Richter's transformation remains a tough disease. And, and we and others are working on several clinical trials looking at new pathways to control the disease, including immune checkpoint inhibitors, using venetoclax. But one of the, couple of other agents which were reported at this meeting, one was actually pirtobrutinib. So the 3rd generation BTK inhibitor, when we use this drug as single agent for patients who had Richter's transformation, almost half of the patients responded to the treatment, and then the response lasted for several months. So that is one, an important agent for patients with Richter's transformation. There is also this new class of drugs called bispecifics, which are basically On one hand, they bind to a protein called CD20, which is on the cancer cells, the CLL cells, or Richter cells. And then on the other hand, they bind to a protein called CD3, which is on the T cells. So what they do is they bring the cancer cell and the T cells together. And that has been shown in several trials to be very effective in diffuse large B-cell lymphoma. And actually in this meeting, there's data being presented of clinical activity for patients with Richter's transformation as well. So I think those are the two important classes of drugs which are being pursued now in clinical trials. And then the third one I should briefly mention is the CAR T-cell therapy that also several studies have started to evaluate for Richter's transformation, but no specific medical data was reported at this meeting.
Okay, so let's pull all this together. People are still in watch and wait, and that's fine if they're not, their quality of life is not diminished, their blood counts are strong, etc. But when they move on to a treatment now, it seems like there's a discussion about which BTK might be right for them and whether or not they should consider a BTK, still investigational, with a second drug like venetoclax. Is that correct?
Yes, correct. Absolutely.
Okay, so you have this whole line of tools that we haven't had for that long. And for people with a aggressive transformation, even there seems to be a glimmer of hope as well. So when you put it all together for your CLL patients, if you had a new patient today, would you say that the likelihood is they can probably live a long and full life, and you have medicines that may not cure the CLL, although sometimes you feel CLL is cured, but they can live long and live well?
No, absolutely. And that's exactly what I tell my patients these days, especially patients who are newly diagnosed. They come for the first visit. Obviously, there are a lot of questions in their mind that for majority, hopefully all patients with CLL can hopefully expect to live a normal lifespan with good quality of life. And as you mentioned, and as we discussed, we have excellent medicines for patients right now available today, and the field is improving. So other important, better medications, safer medications coming down the line, immune therapies coming down the line, CAR T-cell therapies coming down the line. So I really, truly believe that we'll be able to have patients with CLL have a normal lifespan. And I think an important point is that you don't need cure to live a normal lifespan in the context of CLL. You could have a small amount of disease present, but it's not interfering with your quality of life, your blood counts, what you do in your life. You can just continue to live, with a very low level of CLL. So overall, I think we're in a very, very good shape in terms of the treatment paradigm for CLL patients. And I think we're all kind of making really good progress, some of which we heard in this meeting, and obviously, as we will hear in the next few years down the line.
There's one area I have to ask you about that you just mentioned, and that is CAR T-cell therapy. Certainly, I know CLL patients who've had it. It is not yet approved. What is the future of chimeric antigen receptor T-cell therapy for CLL? It's approved in some other blood cancers, but not yet in CLL.
Correct. Yeah. So I think this is one of the biggest advances in the last few years, I would say, in the context of blood cancers. It's approved for many others, not CLL, but many other lymphomas, leukemias, myeloma. I think that for CLL, the field has somewhat lagged behind, and we don't have much clinical data yet. There are a few trials which have been reported, but not very many. But I can tell you that there's a lot of interest right now at this meeting and kind of a discussion in journal with investigators to develop CLL-specific clinical trials with some new constructs. So it's a very, CAR T-cell therapy is very dependent on what kind of gene you insert in the CAR. So it's a very kind of technological heavy kind of a field where even small changes in what gene you insert can make big differences on how patients do. So there's a lot of effort happening in the lab side to develop new constructs which specifically could work for patients with CLL, also for patient Richter's transformation. So I think that's an area where I think many more clinical trials will come in the United States at our center, at many other centers. And I think in the next 1 to 2 years, we'll have a somewhat more clarity of the data in terms of clinical CAR T-cell therapy for patients with CLL, as well as for Richter's transformation.
Okay, so really what you're touching on is can we get the immune system to fight the CLL and do it long-term, correct?
Correct. Yeah, I think from chemoimmunotherapy era to target therapy era, now we are asking our immune system to do kind of rest of the job and kind of take care of stuff. So I think immune therapy works very well for melanoma, for solid tumors. So can we use our immune cells to help get rid of the CLL?
Okay, so it sounds like a great time of progress for those of us living with CLL, with the current therapies, some that may be approved even in the short term, combinations, and then this work going on in immune therapy that's happened in some other areas and whether this pays off for us. Dr. Jain, thank you so much for being with us on the patient story, and we wish you well with your research and your clinical care of patients at MD Anderson. Thank you so much.
Thank you.